So to begin with, about a decade ago, it was estimated that there were 1 million new cases of cancer each year, at least half of which are expected to develop bone mets, and that number is probably even higher now. Adding to that, to increase the prevalence of all of the metastatic bone disease, is that as treatment improves, patients live longer. And then to review, in any patient over the age of 40, metastatic disease is far, far more common than any primary bone lesions. The clinical scenarios that we most commonly encounter are basically two. The first is patient with an established diagnosis of metastatic bone disease for whom either there's a new location of a lesion or progression of an existing lesion. And in both of those situations, the lesion itself can just be treated. The other scenario is a new lesion that doesn't have an existing metastatic bone disease diagnosis. And this includes patients with a remote history of cancer. And in this situation, local and systemic staging is imperative before there's any treatment. Local staging will always include x-rays of the entire bone, CT or MRI depending on the scenario, and a biopsy. Systemic staging includes CT of the chest, abdomen, pelvis, full body bone scan, and blood work, including markers for myeloma, such as protein electrophoresis. To review quickly, the most common primary malignancies that we see causing metastatic bone disease are breast, lung, prostate, thyroid, kidney, and not to forget myeloma and lymphoma as well. When these lesions do develop, there's multimodal treatment available. There's chemotherapy, there's radiation, which is particularly effective for primary diseases such as lymphoma, myeloma, and breast cancer, so much so that surgery may actually not be necessary following radiation for lymphoma and myeloma lesions. And really the last course should be surgical management. So as an example, this is a patient with a very large lesion in his pelvis, 60-year-old male diagnosed with large B-cell lymphoma. And halfway through his treatment, he goes from this lesion to this lesion, where essentially it's all healed. So a diagnosis, couldn't weight bear at all, excruciating pain, halfway through treatment, he can walk. So surgery wasn't necessary for him. Chemo and radiation can be very effective. The clinical challenges that exist are differentiating cancer-related pain from mechanical pain, predicting impending pathologic fractures, and then dealing with destructive lesions without a known diagnosis. Starting with cancer-related pain, it's typically constant and not affected by loading the affected bone. This is usually responsive to non-operative modalities such as analgesics and radiation. Mechanical pain is different, and that presents when the affected bone is being loaded. And this essentially can be thought of as a structural problem, which requires a structural solution. Most people are familiar with Murrell's criteria, which is a scoring system to try to predict the risk of a pathologic fracture. We have 4 criteria: the site, the type of the lesion, the size of the lesion, and the characteristics of their pain, and a score of 1 to 3 for each of those 4 criteria are given. And a score of 9 or greater should prompt consideration for prophylactic fixation. As an example, this is a patient with a lesion in the peritrochanteric region, so they get 3 points for that. They have functional pain, so they get 3 more points for that. Size of the lesion is probably graded as size 2, so they get 2 points there. And it's a purely lytic lesion, so they get 3 more points for a score of 11. So this person would be considered at risk for a fracture, and there should be at least consideration for prophylactic fixation. And the final clinical scenario to review is the patient who presents with a solitary destructive bone lesion. This should always be considered to be a sarcoma until it's proven otherwise, even if a patient has a history of prior malignancy. In these situations, even if there's a fracture, a tissue diagnosis is essential. When we do get to surgical management of metastatic bone disease, the goals are firstly to stabilize the fracture or the impending fracture, preserve the greatest amount of bone stock possible, maximize quality of life, try to come up with a surgical management that's going to have a shorter recovery than the anticipated survival for the patient, and in particular, the idea of 1 operation per bone and something that will allow the patients to use that extremity immediately. Moving on to impending proximal femoral fractures. Ideally, these lesions are treated before there's an actual fracture. And the options are between stabilization and resection. And the other issue to consider is how to address the lesion itself. Once patients develop femoral metastases, their survival decreases. So in a recent study, it was shown that once a femoral metastasis is diagnosed, mean survival is 54% at 1 year, down to 16% at 5 years. So not a very good prognosis at all. But the survival does seem to be better for the group that has an impending fracture compared to those who actually fracture. So here's the survival curve for patients who have an impending fracture, and it drops down to this lower curve here for people who actually fracture. Now, whether that's more a reflection of burden of disease or reflects the actual fracture itself is difficult to tease out, but the idea still is to try to treat these before they actually fracture. And the principles of that are to firstly establish the diagnosis, then to consider the options for reconstruction. You can use stabilization with an intramedullary nail or resection and reconstruct with a hemiarthroplasty or equivalent, and also how to address the lesion. And the options there are to curate out the lesion and do some other form of reconstruction, and also to consider the adjuvant treatments, in particular radiation. The issue of stabilization has been reported on recently in the literature. A recent study comparing intramedullary nails versus resection and hemiarthroplasty showed a higher risk of mechanical failure when an intramedullary nail was used compared to a hemiarthroplasty. 11% failure with the IM nails. And in the rest of the literature, that rate of mechanical failure with an IM nail goes up to as high as 20%. A separate study looking at what are the causes for intramedullary nail failure found that tumor progression and hardware failure were the major causes, and those are pretty related. If the tumor progresses to the point that it destabilizes the bone, it's only a matter of time before the hardware is going to fail. The metastatic lesion itself should also be addressed as part of the treatment. So this may involve curettage of the lesion, and it should always include radiation of the lesion afterwards. And the rationale for this is by treating the lesion, we can decrease the risk that it will progress and therefore decrease the risk that hardware will fail. So this is the example we used earlier of Murrell's criteria with the lytic lesion in the peritrochanteric region. It's a 75-year-old female with metastatic renal cell carcinoma. This was a symptomatic lesion. Quite reasonably, she was treated with an intramedullary nail. You can see from the follow-up x-ray something else happened at the time of the nail insertion because there's a cerclage wire there. But the bigger issue is that this lesion never was treated. And as a result, it continued to grow. Eventually, the proximal femur fractures, and then eventually after that, the nail fails. She was salvaged with removal of the nail and conversion to a calcar replacing type of stem. In contrast, this is a 65-year-old female with myeloma who on x-ray really doesn't have much of a lesion that you can see, but on her MRI, quite clearly there's a lesion in the subtrochanteric region. Because she had pain, she was treated with a biopsy, curettage of the lesion, placement of an IM nail, and adjuvant radiation. Moving on to actual fractures of the proximal femur. So once the femur is actually fractured, the issues are how do we deal with that? How do we reconstruct it? Fixation versus replacement. And if replacement is the choice, one of the current controversies is a long stem or a short stem hemiarthroplasty. Now getting on to fixation or replacement. A couple of recent studies, one of 300 patients, showed that if these lesions were resected and replaced, there's a 3% failure proportion compared to 6% for an IM nail, so fairly similar. But trying to actually fix these with open reduction internal fixation with plating did not work well in that series with a very high failure rate. Almost half of patients failed. A smaller study, also from this year, showed resection and replacement, no mechanical failures, with all of the patients in that series surviving 2 years, compared to the intramedullary nail, where 1 in 10 went on to fail, and only 85% had survived at 2 years. So if we're going to use a hemiarthroplasty for reconstruction, the next controversy becomes short stem or long stem. And the theory behind use of a long stem is that it protects the entire bone, which is a concept that's been talked about a lot, for example, bringing up the idea of using an intramedullary nail. And that relates to the key issue of what's the risk of distant metastases. The advantage of using a long stem is it does protect the entire bone. The disadvantage of the long stem is that it does protect the entire bone, so the entire bone now has a cemented stem in it, and also the potential increased risk of pulmonary complications. Recent study presented at the oncology meetings this past year of 200 cases showed that the overall survival was 40% at 1 year, but there was no difference in stem survival on the basis of stem length. Very few patients actually developed distal metastases, the whole rationale for using a long stem, 2%. And the complication risk was substantially increased with use of a long stem, almost double, and usually it was acute cardiopulmonary complications that occurred. The study then went on to conclude to use the shortest stem, which bypasses all present disease. So an example of a proximal femoral fracture in a 76-year-old with metastatic lung cancer. Recall from the previous slides that that's associated with a mean survival of under 4 months. So he was treated again with a cemented hemiarthroplasty using a stem that was long enough to bypass the present disease but not protecting the entire bone. And to finish up, we'll talk about pelvic metastatic disease. The pelvis is a very common site for bony metastases. Many of these lesions, however, can be treated non-operatively, particularly those in non-weight-bearing areas. And in particular, when you consider that these are substantial surgeries with prolonged recoveries, and we're trying to find a surgical solution or a treatment solution that's going to have a shorter recovery than the anticipated survival. And these also frequently are patients who are quite sick with a limited prognosis. The non-operative modalities that we have available, again, are radiation and chemotherapy, very effective for myeloma and lymphoma. Bisphosphonates and denosumab are also used with good outcomes. And a more recently described technique, a less invasive technique, is radiofrequency ablation with cementoplasty. And there's a few recent studies on this. This is a series of 53 cases combining RFA and cementoplasty. Most of these lesions were in the spine and pelvis. Their primary outcome was only pain at 24 hours, so it's a pretty short-term outcome, but they did show an improvement in that. And in a similar study of radiofrequency ablation compared to cryoablation, analgesic use was decreased in the cryoablation patients at 24 hours. So both short-term studies, but promising results. Another study of extravertebral sites treated with RFA and cementoplasty. 14 patients, all improved in their pain scores, and they didn't encounter any mechanical failures at 6 months. And this is an example of a large lytic lesion in the ilium. This would be an intraprocedural X-ray showing the trocar in the lesion and the cement that's been placed on a post-procedural X-ray. When surgical management is necessary, patient selection is critical. Again, looking to try to pick patients where the anticipated survival is longer than the anticipated recovery. The tried and true reconstruction method is a Harrington Reconstruction, which combines fixation in the pelvis with cement through the defect and a total hip replacement. This is one of the larger series in the literature of 37 patients with almost 2 years of follow-up. Functional scores and pain scores all showed improvement. At 2 years, overall survival was 55%, down to 39% at 5 years. The reconstruction itself, amongst those who survived, 60% were still viable at 2 years. So an example of a pelvic lesion, this is a 58-year-old male with metastatic renal cell, had radiation, that didn't help, was thought not to be a candidate for cementoplasty because there was no containment of the lesion, so he went on to have a modified type of Harrington Reconstruction with pin placement first and then cement around that, and that allowed him to get up and start weight bearing. So to summarize, the management of metastatic bone disease first and foremost requires establishment of the diagnosis. We try to prevent fractures wherever possible. It's very important to communicate with the multidisciplinary oncology teams and the patients, as these are difficult situations, to find the best treatment for a given scenario, and try to avoid prolonged recovery with whatever treatment choices we make. For the particular clinical situations of impending fractures, the issue is deciding between a hemiarthroplasty and an intramedullary nail. But I think regardless, the lesion itself should be treated one way or another, even if just with adjuvant radiation, in order to prevent tumor growth and therefore prevent hardware failure. When patients go on to actual fracture, hemiarthroplasty is probably the treatment of choice, and the shortest stem, which bypasses all clinically apparent disease, should be used. And in the pelvis, maximize all non-operative treatment modalities, and when it's necessary, I think the surgical treatment of choice would be a Harrington type of reconstruction. Thank you.
As most of you know, sacral fractures really, because the sacrum is the keystone of the pelvis and the spine, it involves many types of injuries, sometimes simultaneously, sometimes separately, but it can involve a spinal pelvic dissociation, it can involve a pelvic fracture and more or less isolation, a combination of the two. And that's why fixation of the spine to the pelvis becomes an important means for treating these injuries. So generally when we're talking about sacral fractures, we're talking about two entities. We're talking about the high-speed injuries that have several other factors that have to be dealt with in addition to simply stabilization of the fracture. And then the sacral insufficiency fractures have their own set of problems, just simply because of the comorbidities that the patients have. more chronic, obviously, than in the traumatic session. I'm sure you're all familiar with the three-zone classification of Denis, and so what we're dealing with here is generally, I'm going to basically subdivide these into unilateral fractures or bilateral fractures. And the zone 1 and zone 2 injuries, generally speaking, tend to be the unilateral fractures, whereas zone 3 injuries, although it looks like a nice, neat longitudinal line in the previous slide, is really a complex injury that involves the sacral canal, but often has many fracture planes, longitudinal fractures, transverse fractures, and represents a complete dissociation of the lumbosacral spine from the rest of the sacrum and the pelvis. And it's represented by this classification by Roy Camille. And so that's important to keep in mind when you see the type of fixation that we're using. And so they tend to be these zone 3 injuries, also referred to as Sacral H fractures and Sacral U fractures, and other colloquial type of descriptions based on the injury pattern. And you can see why this is reasonable from a biomechanical standpoint, where you essentially, like just about everything else we do, you secure both fracture fragments, if you will, in a stable manner with pedicle screws in the more cranial fracture fragment and iliac screws in the more caudal fracture fragment. So why don't we do this for every single one of these cases if it's more stable? Well, the problem, of course, is that it's a considerably more complication-prone procedure than percutaneous iliosacral screw fixation. And you can see from one of our publications about 5-6 years ago now, that, and this is in an N, I believe, of 17 patients overall, or maybe it was 18, you can see that there's a significant percentage of patients who have complications associated with spinal pelvic fixation. I think this was early on, and probably, I think we've gotten a little better at avoiding some of these, at least the hardware-related complications, but still problematic. And so if we can get away with iliosacral screw fixation, that's something that in general we prefer. And again, infection, higher rates of infection and wound-related complications. We're often dealing with this type of Morel-Lavallee type lesion. You can see the degloving here. Essentially, you make an incision through subcutaneous tissues, and basically you're looking at a huge void. And so these patients are extremely prone to soft tissue complications, and in some ways, the least that you can do, the better, to still get them stabilized and mobilized. But this is a type of situation, and when do we use this primarily? If a patient requires an extensive sacral decompression, we tend to go straight ahead and proceed with a spinal pelvic fixation. Here's an example. This is from not too long ago, 3 or 4 months ago. This is a 44-year-old healthy, active woman who fell from a ladder, landed on her buttocks, and had complete loss of bowel and bladder function. Now, of course, she had pain in the low back pain as well, and you can see that she's got this Roy Camille type 2, sacral U type fracture, zone 3 fracture with a complete cauda equina syndrome. And in this type of situation, we would move primarily to spinal pelvic fixation. And you can see that the incision isn't much different from what we normally would do for a lumbosacral spine fusion. Even though the hardware fixation looks fairly dramatic, the amount that we actually need to see is not anywhere near as dramatic. And so you essentially have a situation here where what you have to do is, first of all, reestablish length. So reestablish the length of the pelvis, which is attached caudally through the various ligaments to the caudal aspect of the sacrum that you see here. So reestablish the length of the pelvis relative to the lumbosacral spine, okay? And there are a couple of ways that we can do that. One of the simpler ways is simply to use bifemoral traction. And so you can still do that with a patient in the prone position. The vectors aren't always as desirable as you would like, but you can certainly achieve some degree of bifemoral traction and some degree of distraction at the fracture site. And then an extremely powerful way of achieving distraction is with the use of a femoral distractor. And here you have to imagine that the patient's head is to the left, the patient's feet are to the right. This is the right side of the patient over here. And one chance pin is in the L5 pedicle in exactly the same place that the screw is going to go into. So you essentially cannulate the pedicle with the chance pin in the exact same hole. You're going to place the pedicle screw, and the same thing with the iliac screw. So this chance screw is actually going away from us, going laterally and caudally into the ilium. And we can essentially distract across the fracture, so distract the lumbar spine from the pelvis in this manner. Then once you achieve length, you do sacral, and this isn't demonstrated in this slide, but you remove the sacral lamina, okay, so you're doing a laminectomy to decompress anyways, and then you can actually joystick, you just go in between the nerve roots, you actually joystick the upper sacral segment and reduce the kyphosis, and that's when, and we tend to do this in conjunction with with either Chip, Sean, Jim Craig, whoever happens to be taking care of the pelvic trauma that day. And then at that point, the iliosacral screws are placed, and they essentially skewer this fragment and hold the kyphosis into position. And then we can proceed in a neutralization fashion with our spinal pelvic fixation. And this is what her radiographs look like postoperatively. And this patient had actually a fairly rapid, surprisingly rapid recovery of neurological function, essentially as normal bladder and bowel function at this point, 3 or 4 months out. What about unilateral injuries? In general, it's very unusual for us to do spinal pelvic fixation primarily for unilateral injuries. Similar to the first case I showed, it tends to be done in the very few cases where we have fixation failures. And here's an example, a patient with a zone, I believe it was a zone 1 injury with cranial displacement. You can see that there is a percutaneous iliosacral screw fixation as well as pubic ramus fixation. And in this case, 6 weeks postoperatively, the patient started having cephalad migration, rotation, as well as posterior migration of the right hemipelvis. And you can see that on these radiographs as well. On the inlet view over here, the displacement relative to previous, and on the CT scan as well. So similar to before, reestablish length. In this case, we don't have issues regarding decompression per se. It's more of a length and mechanical stabilization issue, and then fixation with unilateral lumbo-pelvic fixation in this situation. So what are the indications for doing primary spinal pelvic fixation in unilateral sacral fractures? First of all, it's not entirely clear, but anytime we're looking at significantly displaced fractures, severely displaced fractures, especially if there's the need for a foraminal decompression or any type of extensive decompression, and then if you add facet joint involvement, these are sort of the factors we look at. And this patient happened to have all the factors. We've got a pretty displaced injury, as you see here. They have substantial foraminal comminution with a corresponding radiculopathy that required a foraminotomy, and they have a comminuted L5S1 facet joint. And so this patient was a good candidate for a unilateral spinal pelvic fixation. What about the role in non-unions? We've already established that this is a fairly stable, or a more stable construct in general. And in this situation, generally when we're dealing with sacral fractures, when you have a non-union, it's not due to poor vascularity. The sacrum is very well vascularized. It's due to the fact that you don't have sufficient stability. So again, one would imagine that adding this type of fixation would help that situation. So a couple of examples of non-unions. This is, as you can see, a fairly routine zone 1 injury. And this patient went on to have the fixation you see here, 2 iliosacral screws and pubic ramus screws, and went on to a non-union, increased pain. 6 months postoperatively, you can see the fracture line as indicated by the arrow. You can see it here on the CT scan, on the axial views. And so in this situation, the patient, the way we normally do these is simply remove the iliosacral screw, do a paramedian exposure, debride the non-union site, bone graft, plus minus BMP, and then place spinal pelvic fixation and mobilize these patients immediately post-op. And you can see 8 months later, this patient was relatively pain-free and had healed nicely. So this is our general approach: aggressive debridement, paramedian exposure for unilateral injuries or unilateral non-unions, and then stabilization first with iliosacral screws. Beware of compression, of course, with zone 2 injuries, but in general in non-unions, that's not a huge issue. Then bone grafting. It's easy to access the posterior superior iliac spine for bone grafting. It's right there. Once you've done your exposure for your iliac screw placement, you essentially, what I generally do is wait until I've placed the screw and then just go above it and harvest bone graft, so I know I won't be compromising my fixation, and then bone graft and plus minus BMP. So the last thing I'll talk about before concluding is the sacral insufficiency fracture. These obviously have different set of challenges from the trauma patients, but the challenge in these patients is the fact that they obviously have usually significant comorbidities. This patient, for instance, had endometrial carcinoma in the past. She's elderly, she's osteopenic, and she has she has severe pain with bladder deficits as well, and can't even sit. And that's one of the problems with these injuries, is you can't just tell patients to stay off their legs and let it heal. They can't even sit often because they're still bearing weight on their fracture when they're sitting. And these aren't the kinds of patients that you can essentially lie in bed for months at a time as their fractures heal. So she was transferred to us from Montana, and you can see that she basically has, a sacral U-type fracture with displacement here, anterolisthesis at the S1-2 level, and analogous to the injuries we just saw from more severe trauma. And in a situation like this, we contemplated, I think this was the first lady we treated like this a few years back, we contemplated various options, and we did this procedure, which looks like a fairly onerous procedure in an older patient. But this patient was able to, essentially she felt less pain immediately after surgery than she had during the course of the previous few weeks because of the fact that she'd had her fracture stabilized. And she gradually regained her bladder function as well, and actually did exceptionally well. And this has become, I think, a very reasonable method of treating and mobilizing these patients early on. And this is something that probably most of you in this room won't have to deal with, but in the spine world has to be dealt with a certain degree of regularity, and you may have to maybe called upon to assist your spine colleagues in fixation of these long thoracolumbar constructs that sustain a fracture, an insufficiency fracture below, as you can see in this situation where the patient has a fracture right across their S1 screws at the bottom of a long construct. This is, I believe, a case that Jens did, and then was secured with the spinal pelvic fixation. So to summarize, when do we use spinal pelvic fixation? First of all, we use it sparingly. It's not something that's done all that commonly at all, even at our institution, but highly comminuted and displaced fractures generally come hand in hand. Any sacral fracture requiring extensive decompression we tend to look at as probably being reasonable to proceed. You've already have a fairly extensive exposure, generally speaking, and you've further destabilized the fracture. Failed iliosacral screw fixation to add additional stability, non-unions for the same reason, and sacral insufficiency fractures to mobilize these patients more readily. Thank you very much for your attention.